Well, hello and welcome to the XR Theater here at VMed 22. This is the first of several sessions in the XR Theater where we'll be hearing a number of short but important talks covering the breadth and the depth of medical extended reality. We've put together a series of hot topics that we think will be of great interest to all of you here in the audience. And the first up is from Veena Somareddy, who is the CEO of NeuroRehab VR. And appropriately, she'll be talking about the efficacy of virtual reality for neurorehabilitation. So without further ado, Veena, thanks so much for being with us here in the XR Theater, and take it away.
Hi everyone, I'm excited to be back at Virtual Medicine and to see the conference going so strong and being part of this community of virtual reality and healthcare enthusiasts. I'm Veena, the CEO of NeuroRehab VR, and today I'm going to talk about our work developing virtual reality applications for physical and occupational therapy. I will discuss how our team is leveraging the neuroplasticity of the brain combined with immersive 3D environments to increase patient engagement, motivation, and aid in recovery by making therapy fun, efficient, and along with the data analytics to provide quantitative feedback on the patient's therapy progress. Each year, millions of Americans need physical therapy after suffering a neurological incident or a musculoskeletal injury. And Joe here is one of them. His stroke left him paralyzed on one side, cannot really move his fingers. But there is hope for Joe and millions of others. The concept of neuroplasticity suggests that your brain has the ability to recover from a stroke. That is, the healthy part of your brain can take over the functionality of the damaged areas, but this requires extensive physical therapy and cognitive training. So Joe, he wants to get better, but physical therapy is expensive. Clinics are far and apart, so transportation is a problem. Only 30% of patients attend all of their therapy appointments. And on most days, he's too depressed or in pain to go to an appointment. And when he does make it to the clinic, he finds therapy tedious and does not want to do it. And with COVID-19, there has been a bigger impact with clinics shutting down and patients not being able to access the care that they need. Moreover, there are only about 24 physical therapists per 100,000 Americans, but the number of people turning 65 and older every day is growing faster than the US population. So there is a need for physical therapists as well as a way to do physical therapy more efficiently with better outcomes. And that is why we develop virtual reality applications leveraging the concepts of neuroplasticity. We provide evidence-based, fun, engaging, and motivating VR therapy exercises. The company is located inside a neuroclinic, so we have access to physical therapists and patients every day who provide us with constant feedback that helps us to iterate our applications. And as we started to work with these patients, we realized that each of them had a whole range of functional abilities that varied vastly from a stroke to brain injury to Parkinson's to MS. So we had to create a whole suite of exercises from upper and lower extremity training, balance, stress and anxiety, as well as cognitive skills, along with the data analytics required for progress reports. And thus, providing a turnkey solution for a clinic to work with the whole of their patient population. Now we'll dive into how we leverage neuroplasticity principles while designing our virtual reality scenarios to help our patients achieve their functional goals. According to Mayer, Rubio, and Duff, their paper about effect of specific or non-specific VR-based rehabilitation on post-stroke motor recovery, they say that employing 6 or more neuroplastic principles during therapy increased outcomes for patients. Mass practice, dosage, and structured practice all have something in common. They have to do with the duration of the session. Mass practice refers solely to one long session the patient is put into without breaks, while structured practice refers to breaks in between therapy sessions. Dosage is the amount of time a patient is partaking in therapy, for example, 3 times a week. For dosage and practice, with the simple setup of VR consisting of a virtual reality headset and controllers, a patient can get a session within a clinic, at home, one long session, or multiple sessions across the span of a week, giving the therapist and the patient the flexibility to create a customized plan depending on the patient goals and needs. Use of affected limb, task-specific practice, variable practice, and increasing difficulty are all principles based around the content of each therapy session. Use of affected limb is important during therapy sessions, especially for stroke patients that need to work on their affected limb or body part. With the VR controllers, we can make sure that the patient can interact with the environment only with the affected limb, therefore helping them perform repetitions, trying to engage their affected size, and inch towards recovery and rewiring the brain to gain function on their affected side. Task-specific practice and variable practice deal with how the objectives of the exercise are being presented. For example, the patient's task is reaching towards the shelf to grab items, and the object that's being placed varies in location. With VR, it is easy to create different scenarios for everyday living activities with different levels of variability and task specificity, therefore personalizing the scenario to the patient's goals and objectives. Increasing difficulty is another important principle of neuroplasticity. Gradually increasing the patient's intensity of training to help them reach their next level of mobility is important. And by utilizing our XR therapy system with the provided tablet, the therapist has full control over the intensity of the training for the patient and can customize the user experience in real time, therefore being able to provide the most effective and challenging exercises during their therapy session. Next, we'll talk about the stimulation and feedback principles. Multisensory stimulation, explicit feedback, implicit feedback, and avatar representation deal with the feedback given to the patient either in real time or at the end of a session. Multisensory stimulation is important, and with virtual reality, you can have visual, tactile, and sound feedback that truly immerses the patient in the environment and they feel like they're transported to a new place. We have seen patients do more than they thought they could because they forget the bias of their diagnosis and their inhibitions and are focused on the task at hand in the virtual world while being fully immersed. Explicit feedback can be restated simply as knowledge of results, while implicit feedback is based upon the patient's execution of movement, could be given audibly or physically by video playback, sounds in the virtual environment, or by the therapist with cues and encouragement. Next is avatar representation. According to various studies, it is shown that people embody their virtual avatars as their own in the VR world. This helps with the transfer of skills from the VR world to the real world when training on everyday living activities such as grocery shopping or cooking. The gross motor movements and the interactions that they do in the virtual world and the task specificity help with gaining muscle memory as well as cognitive stimulation, leading to better skill transfer. Sometimes when patients are able to see their virtual avatar limbs do more in the VR world, it does translate to real world movement. Next, we'll look at an example of how, by leveraging these principles of neuroplasticity in virtual reality, we are helping patients achieve their functional goals.
So Deidre's here working on the game Foul Play. What we're trying to accomplish her with this game is her sequencing and purposeful coordination of her movements. We're also working on her dynamic standing balance, her weight shifting abilities, range of motion throughout her legs, as well as improving trunk mobility. Lots of good things going on with this game for her. Go ahead, DJ. Ooh.
With the case of our undiagnosed spinocerebellar disorder patient, she had an onset in 1991, so she's a chronic patient that has been going to therapy for a really long time. She began VR integration in May 2018 and had ataxic gait and movement. Her goals were standing, balance, dynamic balance, ambulation distance, and fine motor control, and improving her scale for assessment and rating of ataxia score, which is the SARA score. She used our virtual reality exercises that help with rhythmic and dynamic balance, functional reaching, and as well as working on static balance. Before VR integration, her SARA score was 20, and she could ambulate about 30 feet with an assistive device and has less than 30 seconds of standing balance. One of her goals was to unscrew 5 screws in 5 minutes, so therefore improving her fine motor skill. After post-VR integration, her SARA score improved to 14. She was able to ambulate 210 feet without an assistive device and had 2 minutes of 30 seconds of balance time and achieved her goal of unscrewing 5 screws in less than 5 minutes. So we're able to see this real world outcomes in patients with the addition of virtual reality to the normal therapy. And also we have case studies of just VR therapy and our patients gaining incredible outcomes. So with our solution, it is an FDA registered medical device. It has a convenient form factor with just the headset and the controllers, with a tablet for the therapist to control the patient experience. It can be utilized in an inpatient or an outpatient setting. The gamified therapy is highly engaging for patients and provides a new therapy modality for our therapists. There's more than 30 years worth of research that states that VR is effective for physical therapy, and the therapy itself is being reimbursed by insurance. And with our data analytics portal and HIPAA compliant platform, both physical therapists and patients can track the patient progress. So coming back to Joe, he is now more engaged and motivated during his therapy. With our data analytics system, he is able to precisely track his progress along with his therapist. He has seen increase in range of motion by more than 25%. He's able to hold his balance better, improve his muscle coordination, and decrease sway back. He's having so much fun in virtual reality that his cardio is getting better because he's staying in therapy for longer periods of time, therefore increasing duration of therapy. All of this is leading to better functional independence and a happier life for him. It is encouraging and heartwarming for us when we are able to make real world impacts in our patients' life with our solution. Here is the case of one of our spinal cord injury patients who's 31 years old. He learned how to bend, reach, and select items and pick up items and put them in a proper place using one of our library of exercises. So one day he came back and told us that for the first time, after learning these exercises in the VR world, he was able to pick up items from his pantry, do medicine distribution, and also place items in the refrigerator by learning all of these tasks in the VR world. And therefore, for him, inching towards independence in his life. So at Neuro Rehab VR, we're working hard every day to make therapy more efficient, provide superior engagement, better recovery times, as well as great patient experience and satisfaction for our patients, and reduce costs for providers and payers. We're excited to continue our work on building functional therapy exercises so we're part of that continuum of care for our patients. If you're interested in learning more about our solution and our work, please contact us on our website or email us. Thank you.
Well, thank you, Veena, for that inspiring talk and for the work that you do using virtual reality in such a meaningful and creative way. Next up, we're going to hear from Dr. Brian O'Gara from Harvard Medical School, who is an anesthesiologist, and he's going to be talking about the role of virtual reality as an adjunct for anesthesia in the operating room. Thanks for being with us here in the XR Theater.
Hi, everyone. My name is Brian O'Gara. I'm an anesthesiologist from Boston at Beth Israel Deaconess Medical Center, and I'm going to talk to you today about how we use virtual reality in the perioperative space. So as a bit of a background, we do a lot of surgery in the United States, about 16 million cases per year, and the number of surgeries we do are increasing every year, especially outpatient surgeries. And for these surgeries, the patient is expected to go home afterwards. And so really the focus is on returning the patient back to their normal functional state as soon as possible and doing it safely. For about 30% of our cases, we will give intravenous anesthesia or sedation. And really the biggest complication, most common complication is oversedation. Oversedation can cause things like problems with breathing, respiratory depression, airway obstruction, and if unrecognized, untreated, or severe, these problems can be potentially injurious or even fatal. Patients who are at high risk for these complications are those who are older, have higher body weight, or have conditions like sleep apnea, which may predispose them to having a higher likelihood of complications. Another complication that's worth mentioning is postoperative neurocognitive disorders. So there are two main types that we focus on in the postoperative space. Postoperative delirium is an acute, abrupt change in the level of consciousness, which is associated with deficits in attention and memory. We know that from the ICU literature and the hospital delirium literature that delirium is associated with a higher risk of complications, increased length of stay, and is associated with higher mortality in the ICU. And we spend about $160 billion diagnosing and preventing and treating delirium per year in the United States. Postoperative neurocognitive disorder, as opposed to what's thought to be a temporary condition in delirium, is a more long-standing problems with attention and memory that can be persistent over the months that follow surgery. And this neurocognitive disorder can prevent patients from returning to their functional baseline. It can prevent them from going home. It can prevent them from returning to work. And really, if we're going to be conducting surgery to improve quality of life, or at least return the patient to their baseline quality of life, there needs to be a focus on the mental recovery, not just the functional outcome as well. So as we know from our anesthesia literature that there are many contributing factors to perioperative neurocognitive disorders. We know that surgery and inflammation and the pain that results from that are all very strongly associated with delirium and postoperative neurocognitive disorder, but also the drugs that we use to treat them or prevent them in the first place may have positive or negative effects depending on the class. So for example, in our anesthesia literature, there's been clinical trials trying to show that if you titrate the dose of general anesthesia using processed EEG or the BIS monitor, you may reduce the amount of delirium or postoperative neurocognitive disorder. And for patients who are receiving anesthesia for hip fracture, typically a spinal anesthetic with additional sedation, if that additional sedation is titrated to lighter levels, patients may have a reduced risk of delirium. I'd also like to mention that postoperative opioid use is of particular concern, especially recently. Unfortunately, almost all of our patients who are getting surgery will be exposed to an opioid at some time in their hospitalization. And opioid-related adverse events are very common and also morbid. They result in a higher risk of inpatient mortality, increased readmission rates within 30 days, and increased hospital cost overall. And we know that the contribution of overprescribing after surgery of opioid painkillers may have in part fueled an epidemic in painkillers that has spread throughout the country. So it's important to focus on this postoperative complication as well. So we know that the medications that we give in the perioperative arena may lead to severe but also preventable complications. So can we just give less of them? And the answer to that is it's complicated. We don't have a lot of effective alternative therapies at this time, which can replace them. And just giving less of them without providing the same amount of control of pain and anxiety is not a patient-centered outcome. At least I don't know many patients who would be willing to make that trade-off. So we have an urgent ongoing need for these alternative therapies that can simultaneously achieve the two main goals of perioperative care, at least from an anesthesia perspective, that being patient comfort and patient safety. One potential way that we see that we can achieve these goals is through perioperative virtual reality immersion. So we've partnered with XR Health to try and use some of their software and adapt it to the perioperative space. One program that we have included is called Relaxate, and this is sort of guided meditation where the patient focuses on breathing techniques that are meant to promote relaxation and calmness. Another application that we use is called Mindset, and as you'll see here in a moment, we think one particularly useful feature is the environmental immersion. So for our patients who are having surgery or recovering from surgery, to sort of take them to a place in which they are now swimming with dolphins or immersed on a mountaintop or lying in a meadow is a way to be in a much more calming environment than the surgery itself. Another feature that we really like about the XR Health platform is the external control. So XR Health will use this to sort of remotely monitor the patient experience for their outpatient use. But for us, we actually use it as a means to control the experience locally, so next to the patient, but sort of allowing the experience to take place without the patient having to manipulate the system so they can just worry on relaxing. Worry about relaxing. And so another feature that we really like is being able to communicate with the patient via text message, and I'll show an example of what that looks like. So we did a couple of years ago now, did a preliminary trial to see whether or not we could actually use this during surgery. And so this was a small clinical trial, about 40 adults who were having hand surgery at our institution. We excluded people who were less than 18 years old. We excluded people who were scheduled to have general anesthesia, patients who had an infection, had seizures, or an implanted medical device. As you can see in panel A here is an example of our patient who's wearing his head-mounted display and noise-canceling headphones, and his hand is being prepared for surgery. And in panel B is an example of what he was looking at. So he chose the mountaintop immersion experience, and an example of our text to him is in the middle there saying, "Surgery is going great, but if you could, please try and stay still." Our study schema is below there, showing that the patients were randomized to either virtual reality or usual care. It's important to mention that patients in both groups got their nerve block before having their procedure. So their upper extremity brachial plexus block with lidocaine or an alternative was done so that the operative site was numb. And our primary outcome, therefore, was the amount of propofol that was given for really relaxation and control of anxiety on top of that nerve block. We collected data on several other clinically relevant secondary outcomes, and we'll mention those in the upcoming slides. So as you can see here, there were very few patients in the virtual reality group who required propofol at all, about 4 out of the 17. And when we look at the primary outcome, our median total propofol dose for the virtual reality group was 0, as opposed to 260 milligrams in the control group. We also calculated our primary outcome adjusted for the patient's weight and the duration of the procedure, which are both important considerations when you're talking about the dosing of propofol. And it's also important to note that patients in the virtual reality group required a local supplemental block that is another Novocaine injection at the site of the surgery by the surgeon more frequently than patients in the control group. So in terms of our secondary outcomes, the patients who are in the VR group left the recovery area, the post-anesthesia care unit, the PACU, about 22 minutes faster than patients in the control arm. And there was no measurable difference no statistically significant difference in overall satisfaction between groups. And importantly, there was no difference in the patient's expressions of feeling like their pain was controlled or feeling relaxed or feeling anxious between the two groups. So any differences in satisfaction, therefore, are not related to these key factors. On the bottom there is our evaluation of the QuickDash score. So the QuickDash is an assessment that's done to evaluate hand disability. Higher numbers mean more hand disability. So although the differences here weren't significant, there was a fairly dramatic difference in the medians between the control and the virtual reality group, as well as the direction of change between pre and post surgery in the QuickDash score that we thought was very interesting. So in summary, patients in the virtual reality group required significantly less propofol than their counterparts receiving usual care. Importantly, they were able to achieve the same level of satisfaction and certainly control of pain and anxiety without the use of the drug while using the virtual reality immersion. And some of our important secondary outcomes worth mentioning are that difference in PACU length of stay. So PACU length of stay is a very important perioperative efficiency marker. If you leave the PACU earlier, that means another patient can come in earlier. If all of the patients leave earlier, then the unit can be closed for the day. These are all very important metrics. We also mentioned the QuickDash score, the functional outcome, and so we thought that was very interesting. Can this technique for anesthesia actually improve the outcome from surgery? That would have to be shown in a larger trial, but was nonetheless very interesting to us and the orthopedic surgeons. So our limitations: if you didn't have a working nerve block, you were much more likely to get either some supplemental propofol or an additional local block. So that nerve block is really important. This was a very small study, preliminary data. We didn't record a high incidence of those clinically relevant complications like respiratory depression, conversion to general anesthesia, and the intervention was not blinded. So the requirements for propofol are not just what the patient requires to be comfortable. It's what the anesthesiologist or anesthesia provider determines that the patient needs based on their own clinical assessment. And so a true control for that would have to try and take that provider's assessment and minimize the effect of that bias of wearing a headset or not. And then lastly, our postoperative survey asked some really great questions, but we didn't use sort of validated patient-reported outcome measures. So our next steps are to do larger efficacy trials. We're continuing our partnership with XR Health, and we've received funding from the Bird Foundation, the Israeli-US Binational Industrial Research and Development Foundation, and we're planning to conduct 2 parallel clinical trials enrolling a total of 225 patients. So our first population is we'll look at patients who are older than 60 years old having their knees replaced. We aim to enroll 125 patients here in a 2-to-2-to-1 ratio. We'll have 3 arms, and we'll exclude patients with the same list of exclusions that we had for the hand surgery trial, but we will also exclude people with moderate to severe dementia or severe baseline cognitive impairment. So here's our study schema for the knee replacement surgery, knee replacement trial. As you can see, patients will be randomized into 3 groups. The first group will receive the virtual reality immersion intervention. The next group will wear all the same equipment, but only listen to music and not view any VR content. And then the third group will be a sham. They will wear all the equipment, but they will not view any virtual reality content, and they will not listen to music. The patients in the first 2 groups, the VR group and the music group, will actually be administering their own sedation with the use of a patient-controlled propofol system that we've developed. And all the patients in the sham and usual care group will have their propofol administered by an anesthesiologist, as is usually done. Again, all patients will have their nerve block. Patients for knee replacement will also get a spinal anesthetic. And our primary outcome here is the amount of propofol that was given. We're also going to collect data on the other perioperative opioids and sedatives that are required, airway complications, conversion to general anesthesia. But then after the patient is done with their surgery, we're going to be recording things like PACU length of stay again, pain requirements, pain scores, but also using some validated measures to assess their satisfaction with their anesthetic and the quality of their recovery. The next day, the day after surgery, we'll evaluate the patients for the presence of delirium using the CAM, and we'll assess patients' cognition at 2 time points, 1 week following surgery and then 1 month following surgery to get a longitudinal assessment of postoperative cognitive function. And then we'll also be assessing patients' sort of functional recovery from the knee surgery with something called the KOOS Junior, and that'll be at 1 month after surgery. The next population for our second clinical trial will be for patients who are recovering from bariatric surgery. So finished with the surgery, recovering in the PACU. We aim to enroll about 100 patients in this trial, and at this time it'll be a 1-to-1 split. We will exclude the same list of reasons for patients having hand surgery, but we will also exclude those with chronic opioid dependence because some of our outcomes are related to opioid use, and patients with an open laparotomy. So those will be patients who are having their surgery via a big incision and not via laparoscopic incisions. And so as you can see from the schema, we will randomize patients to either the virtual reality immersion in the recovery area. We're hoping for at least 30 minutes of use there, or usual care, which of course does not at this time include virtual reality. Our primary outcome for this study will be the quality of recovery, which asks the patient several questions, but a lot of questions related to pain control, anxiety, nausea, and overall comfort. And we'll do this at the time of PACU discharge. We'll also be collecting information about the postoperative pain, the requirements of the medications required to treat pain, including most importantly opioids. And then going forward through the rest of the hospitalization, we'll collect much of the same information, pain scores, opioid requirements, but also opioid-related adverse events, especially things like nausea and constipation, which in the bariatric surgery population may limit the patient's ability to eat or limit the ability to go home. So what are some of the things that we've learned so far? You know, virtual reality is a very effective immersion technique. It's very effective for distraction, but for big real deal surgery, you're probably not going to be able to use it alone. You're going to need a really effective nerve block or a spinal anesthetic, as we talked about for the knee replacement patients. There are some programming considerations here. So unlike the girl in the photo above, our patients are not going to be standing up and moving their arms and enjoying a gaming version of the virtual reality experience. And so the content needs to be adapted for patients who are predominantly lying down and not able to move their arms. There are additional challenges using virtual reality inside of the operating room. There's a lot of electrical interference from the equipment. There are some engineering considerations for the room itself, which may make it difficult for a Wi-Fi signal to get into the room, or at least establish a very secure and fast connection between the devices that are required. And then lastly, the patients who are having their knees replaced, the surgery takes about 2 to 3 hours. And so the immersion, therefore, will be very prolonged. Most of the headsets on the market will not provide that prolonged of an experience, especially without a charge. And if you're charging the equipment for that long and wearing it at the same time, the patient may experience some heating of the device and discomfort through that. So these are all things that we've learned so far and things that need to be worked out before we start enrolling patients, hopefully within the next couple of weeks. So thank you very much for listening to my talk. I'm very excited to continue this work and to listen to the other speakers during this conference about the application of virtual reality in medicine. But I really wanted to thank the research team at the Beth Israel Deaconess Medical Center for Anesthesia Research Excellence, which is comprised of Ryan Mathura, Melissa Joseph, Julie Mozadeghi, and Nikita Morera, who I really wouldn't be able to do any of this work without these motivated, young, and bright people. So thanks again, and hopefully at some point in the future, I can see you all in person and answer your questions.
Well, thank you, Dr. O'Gara, for sharing with us your work using virtual reality for patients undergoing anesthesia and for sharing your data with us here in the XR Theater. Next up, we're going to hear from Tara Cruz from Crosswater Digital Media, and she's going to be discussing a very important topic, which is the role of XR for helping patients with cognitive decline and with dementia. So without further ado, Tara, go ahead and share with us your work with Crosswater and using XR to help bring humanity back into healing.
Thank you for joining this presentation for Crosswater Digital Media, Bringing Humanity into Technology, How XR Improves Quality of Life for Patients with Dementia. My name is Tara Cruz. I am the Research and Medical Content Director for Crosswater. In this role, and in life, I'm a strong advocate of XR research and technology development in healthcare, including therapeutic use. In the next 20 minutes, I'm going to share an example of why we care about applying technology innovations to healthcare. Some of this is through a very modern lens, exploring the importance of a device that looks like R2-D2's cousin, or programming that creates these human conversational agents, CMEs, while incorporating the science of components as old as time, such as music and human connection. You might be wondering why dementia care is a focus for Crosswater. Most of you probably know someone with dementia. Witnessing a person in the various progressive phases, including the loss of personhood that goes along with it, can be really heartbreaking. Our human side is driving us to help improve the quality of life in those situations, and there are also practical concerns that can be overcome using the same solutions. Dementia care can be challenging at home, and often leads to a need for residential care or day respite care programs. Each of these situations, home care, day programs, and residential care, have areas where technology can help improve the quality of care and of life, both for the individuals with dementia and for their caregivers. At-home challenges include financial burdens, managing troublesome behaviors, caregiver education, and the psychosocial strains on caregivers. In dementia care facilities, staff shortages and lack of training lead to care gaps, which are major contributors to residents experiencing serious adverse events. In that reality, problematic resident behaviors are often addressed using high rates of psychotropic medications. This equates to a lower quality of care, but a modifiable one. Following COVID-19, problems around staffing shortages, damaging patient isolation, and resident loneliness were exacerbated in dementia care facilities. Now consider current predictions that global prevalence of Alzheimer's disease, one condition under the dementia umbrella, will triple from 50 million to 152 million by 2050. And then take a deep breath, because that can all feel really heavy. Technology applications not only offer novel benefits, but scalable solutions to address a rapidly growing population with existing care challenges. Because I appreciate metaphors, I compare the issue around dementia care to a train moving down the tracks, with faulty mechanics, needing to be fixed while the train is still in motion, but not having enough engineers on board to fix it. In that situation, the train is going to need some additional resources. Similarly, it's clear that applying existing solutions is not going to be enough for dementia care. If we stay in the current paradigm, we won't have the staffing, home care support, or increased training opportunities to completely address the situation. As a society, I firmly believe that we don't want to limit ourselves to the existing care paradigm anyways. The point isn't just to do more. It's to do more and do it better. We know there are a lot of issues to come to grips with in dementia care. And as evidenced by all of the smart and creative people this conference has attracted, there are humans ready to leverage technology to meet healthcare needs such as these. It can be tempting to jump into quickly developing deliverables. Responding to existing needs as soon as possible is a respectable enterprise. However, it is important to have validated results drive the direction of development. Building on a foundation that is backed up by research is how we build effective and sustainable solutions, which become the meaningful tools that care providers want and dementia patients deserve. To that end, I consider our research at Crosswater to be part of ethical stewardship for technology uses in healthcare. As an example, I'd like to introduce you to a research project that we completed in Canada, lovingly titled the Albert Project. During this project, we found ourselves in a variety of places. We started this project through the Center for Aging and Brain Health Innovation. They connected us as technology partners for a joint project with the site Primacare and researcher Karen Campbell from Western Health Sciences. Primacare is a network of facilities in Canada providing long-term care and senior living housing with specialty services focused on dementia. In a continued effort to improve quality of life for their residents, they wanted to explore therapeutic technology to address behavioral issues in residents with dementia. We started out with the population, focusing on individuals with moderate to severe dementia as documented through validated clinical assessment scoring. The population included participants over 65 who had exhibited at least one responsive behavior in the previous 4 weeks. Exclusion criteria included epilepsy, legal blindness, and being in end-of-life care. Our initial objectives focused on feasibility, barriers, and responsiveness of outcome measures demonstrating patient health status and general well-being. We strongly believed in the existing evidence that people with dementia exhibiting responsive behaviors, including psychosis, aggression, depression, and agitation, can respond positively to non-pharmacological approaches. We also considered the host of damaging impacts that psychotropic medications can have, including increased falls, hospitalizations, stroke, and mortality. We felt momentum in our pursuits, knowing that initial results could further therapeutic technology in dementia care. Initially, we were planning on a two-pronged approach of spatial audio design and visual content in VR headsets. For all content, we referenced approaches from reminiscence therapy for dementia. This approach builds on the comfort that many dementia patients find through experiences that evoke earlier memories, which are often preserved longer than recent memories during dementia. For the music, our founder and in-house composer, John Michael Adamo, wrote original scores. These focused on genres that would have been popular in the participants' early lives, such as classical, big band music, and other styles. He composed this music without lyrics for the therapeutic value of music without the distraction of words, and set it all to a calming 72 beats per minute. This uses concepts from music entrainment theory, which demonstrate that a listener's physiologic measures, such as heart rate and respiratory rate, will mirror music tempos. For visuals, we opted to predominantly use filmed scenarios instead of digitally created settings for both the realism and the lack of early life exposure to digital environments in the study population. We considered the resident demographics and took elements such as the rural upbringing of many residents into consideration. A field trip to a local farm revealed many willing therapy assistants. When I said initially earlier, that was a hint. Yep, when we were considering the research design, we hit a huge snag. VR headsets have shown meaningful use in dementia care, but my pesky research ethics mind was really struggling with putting headsets on a patient population with moderate to severe dementia who were already often disoriented and agitated. I couldn't guarantee the residents were cognitively aware of the situation enough to be reassured about what the headset was. And remember, before that calming, therapeutic content comes on, a headset is essentially a blindfold, and imposing that on these residents just wasn't sitting right. Furthermore, we were arming individuals who were known to be agitated and disoriented, sometimes even combative, with a projectile, which brings up safety issues, not to mention expense concerns. Initial inquiries with residents at the facilities revealed that the headsets were considered to be too heavy to wear, uncomfortable, and didn't fit well over all prescription glasses. We also considered that we would lose some patient monitoring ability, with the headsets obscuring nonverbal communication, a particular concern for residents who were minimally verbal or nonverbal. These factors against using headsets were creating mounting concerns. So, we decided to pivot within the XR realm. This led us to immersive projection. Little did we know, the timing could not have been better. Besides our earlier considerations, there was about to be a global pandemic, and the immersive projection concept eliminated the disease transmission concerns that come with a wearable device. This also allowed for the residents' room to become the therapeutic environment, with a gentle transition between the media and their real environment, without the disruption of removing the headsets and being more abruptly transported back. We went forth with Phase 1 at a single site, and in Phase 2 extended to additional Primacare sites. The early stages of the pandemic complicated some of the project, but partially due to our fortuitous pivot to immersive projection, we were able to complete both phases. In this talk today, we'll review some Phase 1 findings. In the initial phase, we found 0% attrition. 66% of the participants exhibited a negative behavior at some point during the intervention, such as restlessness and agitation. Through this, we found that visuals such as the Bavarian Alps reminded one participant of World War II experiences, and some aerial city views reminded 3 participants of late spouses. This led to acknowledging the importance of module selection being matched to patients very carefully. We found that 100% of participants exhibited positive behaviors during the experiences, such as smiling, dancing, and feet tapping with music. 33% of participants had reduced psychotropic medications after the intervention. Beyond the quantitative findings, the qualitative elements were extremely moving. The residents self-reported joy from the XR immersion. Resident families noticed improved interactions with the residents and had more to talk about during visits. This was another benefit of the immersive projection over the VR headsets. It encouraged social engagement, allowing participants to share experiences during the immersive media use. One participant who had been nonverbal for a year began verbalizing again. One who previously exhibited pacing through meals began sitting and participating in mealtimes. Various participants had improvements in nutritional intake, and none of the participants required staff time outside of their regular care routine. The sites also anecdotally reported increased staff satisfaction that they believed was correlated with the increased resident satisfaction. During this time, staff absenteeism dropped. We've taken what we learned here and used it to drive our development of software and hardware. Currently, besides enlarging our library of immersive projection and music therapy modules for memory care, we have expanded into the use of AI for conversational avatars, CMEs, who provide socialization, assessments, and therapeutic interventions. We're also finding meaningful applications in healthcare training and in the use of AI as physician extenders. The R2-D2 cousin from the beginning of this presentation is one version of the Realisphere projector, which brings XR into a variety of environments, and can be mobile or installed into a designated space. The AI use of conversational CMEs in healthcare, there they are, has demonstrated healthcare applications, which are growing daily. At each step, our commitment to XR applications in dementia and other healthcare grows. We learn from each outcome and build on each important finding to optimize what we bring to healthcare. The Albert project reviewed in this talk has been a meaningful step in our journey. It demonstrated to us how impactful our work in XR can be. We met individuals who were uplifted by the technology intervention and who expressed a gratitude that moved us. Seeing the benefits that can come through increasing access to this and similar technologies propels us further along this path. As we continue to address healthcare needs through technology and creativity, we welcome and invite you to follow our journey, collaborate with us on research opportunities, utilize these technologies in your facilities and for your patients, and tell us about your exciting projects. Being part of the XR community is an integral part of the work that we do. We truly love our work and recognize that it is part of a larger network involving developers, artists, clinicians, and the needs of the healthcare community. We look forward to meeting you. Please visit our digital booth at this conference, or reach out directly through Crosswater at crosswater.net. Also, this link has a contact form if you would like to collaborate on future research or explore utilizing these technologies in your facility and for your patients in dementia or other healthcare. On behalf of all of us at Crosswater and our collaborators, especially Hiya Technologies and Realisphere, thank you.
Our next speaker is not new to VMed. This is Howard Rose. Howard has been on the VMed main stage before, and today we'll have him here in the XR Theater. He's currently the head of health and wellness at Spatial and has a background expertise in XR design and product development going back many years across many different types of products. You can learn more about him on the agenda and on the website, read his bio. But today he's going to be focusing on the use of sound as an immersive component to amplify immersive therapeutics. So thank you, Howard, for being with us today. And you're up next.
Hi, I am Howard Rose. I'm the head of health and wellness at a 3D immersive audio company called Spatial. And I am going to talk about immersive sound for health and wellness. It's a pleasure to be here at Virtual Medicine. And I am excited to share about how immersive sound is really changing its humanizing health spaces in hospitals, and it can be used for targeted therapies as well. I want to share a little bit about my background. I got started at the University of Washington way back in graduate school. This is my actual mother wearing a 7-pound headset. I've been in VR working on projects with different applications for pain relief, PTSD, lots of different ways to use immersive VR for therapy. That includes Snow World. Many people here know Snow World. Worked on that with Hunter Hoffman in a company I founded called Firsthand. And Firsthand did a lot of subsequent work. We built applications for acute and chronic pain and other types of therapy with immersive headsets. So from that perspective, I want to talk about immersive sound in the real world. So Spatial is not a headset experience, but it is VR. And I'd like to share, this is my go-to definition of VR. Virtual reality is a computer-generated experience that evokes the sensation the experience is real. And the power of this definition is that it decouples our thinking about VR from a specific type of technology. The focus is really on people and how the technology creates an experience for those people. And sound is really a big component of our human experience. So sound is, it gives us clues about where we are, about inside, about outside, about the weather, about certain feelings, and it encodes how we feel in certain experiences and times of our life. Sound is extremely social. So this is a great example of how there's excitement that doesn't get conveyed, excitement from a live concert that doesn't get conveyed very well just through a recording. So immersive sound has the ability to take us into that concert experience and to make us feel like we're there, that you don't really get from a pair of headphones, even if you're using spatialized audio in an HMD or off of your an audio recording. So what is immersive sound? And it's the ability to create that experience, to take the user into that environment and use that power of immersion. It's super powerful for, it's a sense that we have, it's going 24/7. We can't turn our ears off. And yet we take our most vulnerable people and we put them in an environment like this. When you're sick, you're put into a sound environment that's either empty or at worst, it's something like this. So our health system is suffering from chronically unhealthy sound environments. Sound has largely been ignored in healthcare. And this is, the worst case scenario is ICU delirium. So in the ICU, patients are showered by this delirium inducing, they're bathed in noise alarms. And this can cause ICU delirium, which can lead to a significant increase in one-year mortality, especially with seniors. So we need to change this environment. We need to change this. But I wanted to talk about where immersive sound has been up till now. So immersive audio in real spaces has been around with us for decades, but it really hasn't changed. And if you think about this, you've got various systems, Dolby Atmos, you've got systems that are run inside of theaters, but what's been missing? What's been missing is this trade-off between fidelity and reality. So in these systems, you really do get a high fidelity sense of immersive audio, but it's very fixed. And it's not, you can't move in the space, and there's really one sweet spot. It's fixed and it's not interactive. So you can't really interact with the sound. And also it's extremely structured. The way that the audio is created is designated to specific speakers. There's one sweet spot in the room. There's a lot of reasons that immersive audio has not been more widely used, and that's because of the technology that's underlying it. So Spatial is a company, we've created a platform, and what's different with Spatial? Spatial is nonlinear, it is object-based or audio. It uses real-world acoustics, so it can adapt, and it can work in any size space. So Spatial is sound that reacts. It's dynamic experiences. As this little graphic shows, you have real speakers. That speaker array could be as small as a room. It could be as big as a stadium or a theme park or a hospital campus. So in this image, you can see an example of how sensor input can detect a person, and you can change the output, the little hello on the screen. So I want to share the parts of the system. I also want to tell you that Spatial is free for non-commercial use. So if you are doing a study or teaching your students, you can download our tools, our platform, and use them for free. If they're implemented in a clinical environment, which is a commercial environment, there is a license associated with that. But please, we invite you to download the tools and try them. So here's what Spatial is. So the center of Spatial is a creative tool for real-time immersive soundscapes. So this is a tool very similar to game engines like Unity, Unreal, things like that probably most of you are familiar with. So you create objects. If I'm creating, for example, a virtual forest, I can create virtual trees. They respond to physics and wind and all of that. I create virtual birds. They can fly around from tree to tree. And I create a scene. I can have a river that's flowing over there. Each sound has a box of roll-off. It how large the sound is. Is my river a creek or is it the Nile? I create this soundscape, and then I can play it in real time on any, the genius of the system is that it figures out how your speakers are mapped and how big your space is. And then it figures out how to play that soundscape on your audio system. So because it's real time, we can take any kind of sensor input, and that's a biosensor, that's a physical sensor, cameras respond to time of day, respond to any kind of data stream. And we can also send out any output. That could be a set of lights, it could be lights in the room, it could be other pieces of software. It can talk to Unity, Unreal, and we use OSC, so you can talk to any kind of MIDI or other device that way. So it's intelligent and it's connected. And I'm going to move my little screen here. It's intelligent and it's connected, and real-time audio has never been quite like this for immersion and using it for health environments. So I want to talk a bit about that, but just to round out this story here, is the last piece of this is that, so it is run on a Mac Mini or a Mac OS. Our entire system runs on Mac OS, and you can basically out of a Mac Mini, you can get about 64 channels of audio, of independent audio, and that can sit off in a closet. You have it, some type of amplifier that gives you individual discrete channels for all of your audio, and then you can control it with a phone. So the phone allows you to choose a soundscape, and it also allows you to queue events. So you can have actual event input from the user. You can play and download the soundscapes, and it maps out this is how you actually map out your speaker space. So those are the components of the system, but really what does it bring? The important thing is, how does this change what we can do with immersive audio in medicine? And there are three important requirements for bringing any kind of technology to meet the demands of modern medicine. The first one is precision. Sound needs to be able to be targeted like a drug. And this has never been possible because most sound systems, like the ones we talked about, they're linear sounds. They can't be modified. They don't really respond. And even systems like Unreal or Unity, you can't do the types of things with a sound space that we're talking about. They're primarily designed for delivering spatialized audio in headsets. So this is the first time that we can actually do immersive sound in live spaces that can be extremely precise and controlled. The second is standardization. We need clear protocols that enable us to understand what the outcomes are, to enable a doctor to prescribe it, to enable a patient to understand understand what they can expect in terms of outcomes. And then personalization. We need to be able to use sensors and make that immersive experience respond to the needs of a patient, either right now or through the course of their treatment. So some of the applications we're working on, the kind of obvious first area is emotional lift. So humanizing healthcare spaces. This can be done with either creating ambient sound in a space, such as a waiting room or a lobby or even a treatment room sometimes, and sound masking. So as in that example that I gave of the ICU, you can, to a certain degree, with sound, mask other sounds and potentially reduce the stress that for the patients and for the workers. And we'll talk about the workers in a minute. So reducing stress, fear, depression, anxiety, social isolation. Those are fairly obvious, I think, for people who think about sound, but there's far more that we can do. Physical and behavioral health, there's a lot of ways that we can use sound as a modality for therapy. So one area is motivation, increasing adherence, reinforcing and encouraging health habits. PT and OT, there's lots of ways that we can enhance what happens for different kinds of sensory and cognitive disorders. The current therapies that for sensory and cognitive disorders for ADD, ADHD, autism spectrum, they use a lot of multisensory integration. So by using the audio and integrating that with biosensors or physical sensors or body tracking, we can enhance what happens in those therapy spaces like sensory gyms. And we can also create kind of a way for people to do that outside of those physical spaces. Neurological disorders, stroke, Parkinson's, a lot of these, there's some really great research on how Parkinson's responds to, Parkinson's patients respond to rhythm, and that enables them to walk or to do other things or to move their limbs more smoothly. Stroke, there's a lot of interesting research, which I do not have time to cover here, about epilepsy and the correlation to sound. So the last one is really in the delivery of care. We want to tame the noise. There's a huge problem with attrition in healthcare. A lot of people are leaving the field just because of stress. And part of that really is the noise and the stress that is in those hospital environments. When you have stressed out people, stressed out caregivers, stressed out doctors, and stressed out patients, communication really suffers. So if we can lower that emotional temperature in the room, we can reduce conflict and aggression potentially. And that can lead to a lot of real benefits downstream in patient care. When you can offload some of the care of patients who are in pain or suffering in other ways, this can reduce the workload for the caregivers as well. And then there's potential to use this as a way, to use sound as a way to train response and to train people to deal with the environment of the hospital, because our ears are really key to situational awareness. Here, I want to give a few examples of how spatial, and we're using this technology in hospitals today. So one instance, one example I want to share is Wellstar Health System. They're a health system based in Atlanta. They have 11 hospitals and hundreds of health clinics. And their problem was exactly that during COVID and the pandemic, particularly their staff were under high stress, and they have, like every other hospital system, a problem with people burning out. So they created wellness rooms they've launched them in 4 of their hospitals. They're going to put them in the rest. And they've been running for about, at this time, a month and a half of real use. So they've created these wellness rooms in very central places inside of their hospital. And it's an oasis for the staff, for the doctors and the nurses, to be able to get off the floor and go into a private room to relax and de-stress. One of these rooms consists of massage chairs. There's a massage chair in a private room and spatialized audio. So the person can go in there and get away, be immersed through sound, and get over the relax, de-stress, etc. So just some of the results that they've been reporting from there. They've had over 1,000 people moving, going through the wellness rooms. They were, WellStar was concerned that people would not use it at all. That it, in the culture of the hospital, that it would be very difficult for the doctors and the nurses to even get time off of the floor to physically go down to a place, and that the friction there would just be too much and people just wouldn't utilize it. This has not been the case. They are getting high use. WellStar is extremely pleased with the outcome and the uptake and the reuse, and that speaks to both the level of stress that people are under, and the fact that they are really seeking out other kinds of ways to de-stress. And they've responded very well to these wellness rooms. And we're excited about bringing that to the rest of the health system. We're also working with WellStar to bring this to other parts of healthcare. And I wanted to share a bit this is Dr. Hank Capps. He is a senior vice president of WellStar and the head of WellStar Catalyst, which is their innovation group. I just want to share this video.
We're so excited to think about how the sound experience interacts with both the experience of a patient and consumer in their healthcare journey, wherever it's at. And then the added dynamic that same sound has therapeutic impact and actually can improve the outcome, not just from the experience itself being better, but also from the science of the sound, is really exciting and really fascinating. When I think about spatial and the work that you guys are doing here to create this experience and environment in whatever setting, it's the exact kind of capability and solution that fits into that future of healthcare, because whether it be a recovery room or an experience in a waiting room or in a team member wellness experience, it's all driving toward the same thing and providing comfort to people when they need it the most.
So I'd just like to point out that when we really start thinking about humanizing these health spaces, it brings up a lot of relevant issues about what the hospital of the future should be. What should it feel like when somebody walks into a hospital? How do hospitals serve their communities better? How can we deal with health equity issues? Not all of these issues clearly relate to sound, but when you start to think about reinventing the hospital, an example is that WellStar has created health parks in their communities. These are in real retail spaces in the Atlanta area, and they don't feel at all like a hospital. So when you walk in there, there are fountains, there are plants, there are other things. There's no waiting room. So when we move away from this industrialized sort of vision of what a hospital is, this large monolithic institution, we need to humanize those spaces today and make them more accessible, warm, reduce fear and anxiety for people who are coming to those places. But also we need to think about the hospital of the future and what that could potentially be. So when we create soundscapes, just to talk a bit about that, they can be either a naturalistic environment. We've created things, everyone loves a whale, and some of us love a cat. So this is one we created. It's called Purr. These are all soundscapes that that have been built for WellStar in the recovery rooms. Another component, we're working with our partner HealthTunes, and Walter Rosawa is giving another talk at Virtual Medicine. I hope you check that out. So HealthTunes is a system for bringing targeted types of music experiences for different that are linked to different goals, such as relaxation, or different types of disease states, such as or for chemotherapy, stress reduction, or different kinds of things. Great system, healthtunes.org. Go check it out. And one of the things that HealthTunes brings is auditory beat stimulation using beat frequencies and other entrainment approaches to induce brain states that are conducive to relaxation and stress reduction, or activates other parts of your brain to help people get over certain conditions and disease states. So these ABS frequencies are built into these soundscapes. So in WellStar, people can choose to hear a soundscape with or without ABS. And what they're finding actually is that ABS is that the users who have chosen to use the beat frequencies and the entrainment have higher. They're actually this is preliminary data. WellStar is doing a more longitudinal study, but they are the people who are using ABS report higher satisfaction, and they also are repeat using. They are using it more. So another example. So that's working with the workers, but we really want to ultimately help patients. And so in terms of moving immersive sound into different types of therapy and changing the patient experience, I want to talk a little bit about birthing. So we are working with Reach, and they have a platform. Reach is a global nonprofit that is doing some great work in lots of different areas of healthcare. It's led by Fran Ayala Somayajula, and please check out Reach. Their URL is reachtl.org. They have created a platform called Happy Mama, which is focused on improving maternal health. And we're working with them to take their platform and bring it into the context of a birthing room. So using spatialized audio, again, HealthTunes is providing content there, and we're working with Louis Schwartzberg at Moving Art. If you're familiar with that, you can check out that on Netflix. Louis' stuff is amazing. It's beautiful. And this is a model that really exemplifies how spatial works with people. So spatial is a platform. You can use it to achieve your goals if you're a content creator, to bring your content using our platform for immersive sound and these other types of experiences in therapy. If you're a researcher and you have therapies that you are exploring or that are proven, this can be a way to deploy that at scale. And we also work with different healthcare providers or solution providers, such as Reach or WellStar, that is really trying to reinvent the hospital of the future. So that is my presentation. I hope you will check out Spatial. My email is howard@spatialinc.com. And I hope you will contact me and consider how immersive sound with our system or whatever system you're using. Sound is kind of that last thing that people think about when they're creating a virtual environment or creating a space, a physical space. And we need to pay more attention to sound because it's having a huge impact. And if we harness it well, we can turn that impact into a real positive change. So thank you very much for your attention. I hope you will check out Spatial, and I hope you'll start thinking about how immersive sound can really change healthcare. Thank you very much.
Well, thank you, Howard, for teaching us more about the power of acoustic immersion here in the XR Theater. Now, next up, we're going to hear from two speakers from the Veterans Health Administration, VHA or the VA. I myself trained in the VA. I worked at the VA for many years. I got a Health Services Research and Development Career Development Award from the VA, and much of my initial career was spent at the VA. So I have a soft spot, I should say, in my heart for the VA. And of course, the VA has been really at the forefront for many years in the application of many types of technologies. Of course, electronic health record is one, and many others, but also virtual reality has been used broadly in VA and in the Department of Defense for managing a variety of different conditions. For example, PTSD from combat is one that Skip Rizzo has talked to us about earlier in the conference, and is an area that the VA has been greatly interested in. Well, today here in the XR Theater, we're going to hear a talk entitled Medical Extended Reality in the VA, Defining the Art of the Possible. We have two speakers. The first is Anne Lord-Bailey, who is the Director for Clinical Tech Innovation for VHA Innovation Ecosystem, and she serves as the lead for immersive technology. And our second speaker is Angela Gant-Curtis, who is currently leading the effort to stand up the new VA Office of Information and Technology Innovation Unit in the Office of the Chief Technology Officer at the VA. So I look forward to hearing what's going on in the VA with MXR. Thank you both for being with us here in virtual medicine.
Thank you all for joining us today for our talk about medical extended reality in VA and how we're working to define the art of the possible. I have the distinct pleasure of presenting with my colleague and friend, Angela Gant-Curtis, who's really leading innovation and emerging technology under the Office of the Chief Technology Officer. I'm Anne Bailey. I'm a pharmacist provider by background, but now get to serve as the Director for Clinical Tech Innovation for the VHA's Innovation Ecosystem. Angela, I'll hand it over to you.
Thank you, Anne. Let me first start by sharing information about the Department of Veterans Affairs, its agencies, and our mission. The VA is one of the largest agencies in the federal government, and its mission is to take care of our veterans who served in the military and for their family members. We have three different administrations that provide the support to our service members and their families. First is the Veterans Benefits Administration, who's responsible for providing the services related to education and insurance, housing, and loans. The other larger administration is the Veterans Health Administration. This is one of the largest healthcare providers in the country, providing services at over 170 locations, both in CONUS, Puerto Rico, Guam, and Manila, to our service members and veterans in those locations. In addition, we have our National Cemetery Services, whose responsibility is to take care of the end-of-life services for family members and helping to bury our service members across our national cemeteries. I'm located at the agency level in the Office of Information Technology, and our responsibility is for providing the infrastructure support that's needed to run systems, such as our extended reality solutions across the agency. In that role, I've also recently been responsible for expanding up our VA Innovation Unit, and this is to bring all of our innovative and emerging technology efforts together so that we work to collaborate, evaluate, and coordinate solutions that we deploy for use in carrying out our mission and taking care of veterans. With this role, we ensure that there is always an infrastructure and environment that's available for deploying solutions, such as our extended reality solutions, so that there is no barrier to entry when we want to evaluate and test out these solutions and ultimately deploy them as enterprise solutions across the country. So we're happy to have Anne partnering with me and the rest of the innovations team to bring these solutions to reality. With that, Anne, I'll turn it over to you to talk about how we're using extended reality in both training and immersive therapy for our veterans.
Thank you so much, Angela. And I want to zone in on what you mentioned about the Veterans Health Administration, because we're so grateful for the work that the VA Innovation Unit is doing to thread together the administration at all levels. So we want to just take an opportunity to zoom in on how all of that work then trickles down to what we feel like is most important, and that's the impact on the veteran's life and how we're reaching staff and veterans more expansively, thanks to the work of VA Innovation Unit and that collaboration and coordination. So about 5 years ago, this is what medical extended reality looked like in VA. There were a few sites doing a few things, mostly led by individuals who are particularly passionate about medical extended reality. Each of these sites may have existed without knowing that any of the other sites were doing similar work. Lots of lessons being learned, lots of obstacles being identified, but no one was talking to anyone. And so we recognized an opportunity and a need to begin to thread things together. So in 2017, 12 frontline staff, more than 5 sites, but not many more than 5 sites, were doing very siloed and disconnected work, valuable work, but work that was really inhibited in the area of growth because we didn't know what anybody else was doing. So because of this new approach to things such as how the VA Innovation Unit is enabling things to grow and lowering those barriers to entry, as Angela mentioned, we now have over 750 frontline staff and leaders engaged in our VHA Extended Reality Network, over 127 sites. We lead and support 3 different communities of practice, and our communities of practice continue to grow month to month. Our largest community of practice is focused around virtual reality and its use in VA as a whole. We also have 2 specialty communities of practice, one related to prolonged exposure and PTSD and mental health, and another related to employee wellness. And so what this map in 2017 showed us was a few sites with a little bit of interest with not a lot of connection. But because of connection, collaboration, coordination, beginning to work together and build those communities of practice, we now have a map that looks like this, where we have those 127 plus sites. We have over 700 staff engaged, and people are beginning to share resources and share lessons learned. And you can imagine this type of work couldn't happen without groups like the VA Innovation Unit really working hard to lower the barriers and build that infrastructure for so that this could be something that's long lasting as we learn more and more about how medical extended reality impacts veterans and staff. Some of my favorite things to see are the pictures of our staff and veterans using medical extended reality, and even more so to hear some of the quotes and some of the stories about how people's lives have been changed. You'll see on this slide, we have staff being trained to use medical extended reality in rehabilitation and physical therapy and occupational therapy, some pre-surgical planning, lots of different categories. We have over 20 different use cases of medical extended reality across VA right now. You also see on this slide, we have veterans who are using it, and you can see from their faces the difference that it's beginning to make and continuing to make. On this slide, you'll see Ms. Rogers, who's actually a veteran in one of our community living centers, similar to a nursing home. And she had been confined into this very small space for a long period of time. It was where she lived. It was all that she knew in her most recent and present reality. But because of medical extended reality, we were able to offer her an opportunity to walk through the Western North Carolina mountains. And she was actually able to recognize some of the area because it was the area where she grew up. And you see there also one of our veterans who's experiencing medical extended reality as he was proceeding to palliative care and even into hospice, and was able to recall some things he'd forgotten and think about some of his more positive experience with his grandchildren and tell those stories to us while he was having these positive experiences with medical extended reality. So we've been excited to see these things grow, and we look forward to seeing them continue to grow. We couldn't do it if we weren't an integrated healthcare system where organizations across VA are beginning to work together. Office of Information and Technology, the Office of Healthcare Innovation and Learning, the VA Innovation Unit, tying that all together so that ultimately we can provide impact and opportunity to our staff and veterans. So we are eager to take your questions and also offer for you to reach out to us anytime at the VHA XR network at va.gov. And we thank you so much for being with us today.
Well, thank you so much, Anne and Angela, for sharing with us what's going on at the VA with medical extended reality. There are always innovations happening at the VA health system. So with that, we're going to end this session of the XR Theater. We will be meeting back up again at 11:30 a.m. Pacific time for the next session of the XR Theater. As you can see, there's a lot of programming in VMed 22. You can't see it all at the same time. So you have to pick and choose where you want to go for the sessions and the live chat. But remember, if you miss a session, you can always go back and watch it on demand. All the videos will be available after the conference is over for 12 months for everyone who registered for the event. So just remember that, and then pick and choose where you want to go in the meantime. So now we're going to take a break, and at 11:30 we'll be back. But in the meantime, you have some time to take a quick look over at the virtual exhibit hall, where we have a whole wide range of MXR companies presenting all sorts of hardware and software solutions. Take a look, see what interests you, spend some time talking to the representatives, learning more about what's available. You can't see it all on every session, but over the course of the 2 days, you'll be able to check out all 20 booths and learn all about what's been going on with this whole wide range of opportunities for MXR. So we'll see you back soon, and I hope you're enjoying the conference.
you.